Ladies and gentlemen, health policy after Obamacare. If the topic didn't confuse you, it did me, because I thought we were in Obamacare. Didn't know we were after it, but I guess the panelists will explain that. We have two distinguished panelists, Dr. Ezekiel Emanuel and Dr. Mark McClellan. Dr. Emanuel, Zeke, is the Diane, Levy, and Robert Levy University Professor of Healthcare Management and Professor of Medical Ethics and Health Policy at Wharton, the Perelman School of Medicine, University of Pennsylvania. He has written and edited 9 books and over 200 scientific articles, and he is currently a columnist for the New York Times. He asked me to mention that his memoirs are being published in 2 weeks, so they'll be out in 2 weeks, his memoirs. He did not ask me to mention that his brother is the well-known mayor of Chicago, Rahm Emanuel. Mark, Dr. McClellan, is the director of the Engelberg Center for Healthcare Reform and the Leonard D. Schaeffer Chair in Health Policy Studies at the Brookings Institute, and he has twice received the Kenneth J. Arrow Award for Outstanding Research in Health Economics. And they'll each speak, and then we'll do Q&A. Thanks.
Thank you. Well, it's a great pleasure to be here and to speak to you. And I want to thank, you can push that slide back. I'm not ready for it yet, please. Push the slide back. Well, I thought I controlled things. Thank you. And I noticed that in the previous audience, in the previous panel, that there was a picture of the Capitol behind the speakers, and it was a little disconcerting to fly all the way out to Stanford to see Washington, D.C. again. Not a good thing. So, it's a great, as I said, a great pleasure to be here, and I am a little intimidated because my mentor, from whom I learned almost all my health economics, but after this speech he's going to disavow that. Vic Fuchs is in the audience, and great. I'm sure he'll ask the first question and tell me why I'm wrong. So let me begin by trying to put U.S. healthcare spending in some kind of context. Last year in 2012, the United States spent $2.87 trillion on healthcare. Now, I know a lot of you are masters of the universe here in California. You've got familiarity, of course, with millions, more familiarity with billions and tens of billions. But 2.8 trillion is something that most people don't have a lot of familiarity, even if they're in the money management business. That number makes the United States healthcare system the 5th largest economy in the world. We actually spend more on healthcare in the United States than the entire French GDP. It's more than they spend on those great French food, that great French wine, vacations in the Riviera, Peugeots and Citroën crappy cars. It's really hard to believe how big the United States spending is. If you look at federal spending, so federal spending for Medicare, Medicaid, the Indian Health Service, the Federal Employee Health Benefit Program, the VA, and you add it all up, you're somewhere in the range, and it actually turns out to be harder to add up than you think. You're somewhere in the range of $970 billion. And phenomenal amount of money. Actually, just the federal portion of Medicare and Medicaid is the 17th largest economy in the world. The federal portion of or Medicare and the federal portion of Medicaid actually is bigger than the economy of Turkey, the Netherlands, and Switzerland. Now, I don't know whether you're on the left or the right of the issue. I don't think it much matters. But when you see those kind of numbers, you have to believe we need some entitlement reform. But I think the issue is what kind of entitlement reform. I am not for premium support. It actually doesn't bring down total health care spending. It sort of just shifts around the pots. And what we need is entitlement reform that actually brings down health care spending. And I'm going to make a pitch that that is focused primarily on changing how we pay doctors, suppliers, hospitals, and others. Now, I want to put U.S. healthcare spending. Now we can have those slides. Somehow, if I could control it. No, not that slide. That slide. We're having problems with the slides, and I sent them in on Monday. So this is, as I like to tell my students at Penn, the most important graph in health policy. On the x-axis is per capita wealth, per capita GDP in the country, so it's how rich a country is, and the y-axis is per capita spending on health care. And you can see there's a nice, very tight correlation there among countries. Many of you who are in the economics field will immediately recognize that this is not the characteristic graph of a basic necessity. Most doctors think they provide a basic necessity. There's a characteristic graph of a luxury good, and I always challenge my doctors, well, why are we providing luxury goods? You can see that every developed country is on that graph. The R squared is 0.88, and I've defied people to find another graph with such a tight correlation coefficient in the social sciences. Typically, you have to go to chemistry and physics, which were my undergraduate majors, to see those kind of relationships. And then about 5 months ago, the New England Journal publishes this graph, which is chocolate consumption by Nobel Prize winners. And you get an R squared there of 0.79. And the authors in the text point out, well, Sweden, you know, they give the Nobel Prize, so they might be biased. And if you actually take Sweden off the graph, the R squared goes above 0.8 to 0.83. So this is the only other place I've ever seen in the social sciences where you get such a tight correlation. More dark chocolate for Stanford. But I want to just go back to this. You can see that the United States is well off this graph. And by the way, these data are from 2006 because McKinsey did this very nice graph in 2006. But the graph holds up for 9, 10, the latest data we have. We are about $700 billion off that line. We spend way more than we should. I was trained, I have a PhD in political philosophy, and the philosophers say you can't conclude what we ought to do from what is in the world. On the other hand, when every other country is on that line, it's really hard to say why that line isn't where we ought to be. Now, the third point I want to make is that we have seen a tremendous slowdown in healthcare spending for the last few years. Now, a lot of people, you can see this line, and what you can see is that from roughly 2004, 2005, we've had this, that's the blue line, NHE is National Healthcare Expenditures, this slowdown going way down, and the red line is GDP change, and you can see the big recession. This is a very important graph in my opinion, and the first point is that it slowdown predates by many years, 3 to 4 years, the recession. So there's no doubt that the recession has had a big impact on the slowdown. You can see it here, big accelerated drop. But we have had a slowdown in healthcare spending on a per capita basis before the recession. This is another way of putting it. If you look at spending from 1970 to 2010, we've had GDP plus 2.7 in healthcare. That's why we've gone from 6% of GDP in healthcare to 18% now. But you can see that the projections, this is which affixed to the doctor formula, is basically flat per capita, flat in the national, this is Medicare spending, and this is with no doctor fix, which would take money away from doctors' spending. And you can see, regardless of whether we fix or don't fix, we are going to have a huge slowdown in Medicare spending on a per capita basis. Medicare spending is still going to grow because, of course, with the baby boomers, we're adding about 3% more population per year. But this slowdown is incredibly important. There has been a big disagreement as to why we're having the slowdown, and I think it's a little early for definitive answers. One answer is, well, we had a recession, but as I've shown you, and that slowdown predated the recession. So the recession can take some of it. It did accelerate the decline, but it's not all of it. I think we have had big insurance redesign issues, which account for it, putting more out-of-pocket expenditures on the public, and that has some effect. I don't think it's a huge effect. We've had a drug pipeline issue, a lot more generics in the system. I think Mark will talk about that. A large part of that is the change in Medicare coverage of drugs. We got Part D under Mark McClellan, and we've actually seen a big shift in the use of generics from under 60% before Part D to north of 75%, and I think that partially accounts for it. I think we've also had changes in the delivery of care and how doctors and hospitals and others deliver care, and I think we had some early phase shifts that are beginning to show up. So my fifth point here is I'm going to make a radical projection here, state my reputation on it. I know that Vic Fuchs will object to this. I actually think we're going to go pretty close to GDP plus 0 by the end of the decade. And that, in fact, this slowdown is going to go even further. A large part of that is catalyzed by changes that we put in place in the Affordable Care Act and Obamacare. But let me tell you where I see things happening. First of all, there are lots of incentives in the Affordable Care Act to change how hospitals deliver care. They, for example, include penalties for hospital-acquired infections, for medication errors, for falls, and other things. Hospitals are all taking these seriously. They're pretty expensive. Just to give you an indication, a central line infection costs on average about $45,000 per added case. You reduce those, there's some money there. We put in some penalties that are about to kick in, they haven't kicked in yet, on readmission rates to try to reduce how frequently patients with congestive heart failure, acute myocardial infarction get readmitted to the hospital. Prior to the bill, it had hovered between 19 and 20%. Yesterday, there was a report that in September of 2012, they had dropped down to 17.8%, a noticeable change. Hospitals, again, are focusing on this because they're going to be penalized if they don't get them in order. But I think the real essence of how we're going to reduce spending on health care has all to do with chronic conditions. So the fact of the matter is that this is the second most important graph in health policy. Let me first draw your attention to the itty-bitty bar there. What that bar says is that half the American population is essentially out of the healthcare system altogether. They spend 3.2% of total healthcare spend. Who are those half? A lot of Stanford students, kids, 20-something-year-olds. You know, they might need some antibiotics for a strep throat. They might need some stitches from too much frisbee or bicycle riding in this place. But essentially, they're not using the healthcare system. On the other hand, 10% of the population uses nearly 2/3 of the dollars. And as Willie Sutton, the bank robber, used to say when he was asked why he robbed banks, he says, that's where the money is. So if you want to get costs under control, you don't focus on the healthy people, you focus on this 10%. And who are the 10%? They're people with chronic illness. Congestive heart failure, COPD or emphysema, diabetes, hypertension, my field, cancer. They're going to be the key to saving money. And I like to say that the key, therefore, is prevention. Now, the moment I say prevention to a lay audience, they think, oh, vaccines, cancer screening tests like colonoscopies or mammograms or pap smears. But we mean prevention, tertiary prevention. That is, taking people who have chronic illness, keeping them healthy, preventing them from going to the emergency room, preventing them from going to the hospital. That is going to be the key. So on the long-term basis, we need to change how we care for people with chronic illness. We already have good indications that that can be done and can be done in a dramatic way. So let me give you just a couple of examples. If you look at CareMore, which is a Medicare Advantage, that's a Medicare managed care plan in Southern California, has an outpost in Arizona and Nevada, was about a year and a half ago bought by WellPoint for $800 million. You look at their management of patients with chronic illness. They have a very intensive set of plans. They take care of patients on teams, not individual doctors. They have specialty clinics. So if you are a diabetic and you have a wound, you don't go see your primary care doctor. You go to a specialist diabetic wound care clinic where the best nurse takes care of your wound. They have a lot of intensive programs like fall prevention programs. They even run a transport service for chronic for patients with chronic illness to bring them into the hospital, into the office, instead of sending them to the emergency room. They have a phenomenal record. Their amputation rate is 60% below normal. Their hospitalization rate is 24% below the competition. Their hospital stays are 38% shorter. And by the way, their cost structure is 18% below conventional Medicare. I've been studying an oncology practice in the Philadelphia area that has similarly done a pretty big re-engineering of how they care. They've got an electronic health record with voice-activated notes, so everyone has a note by the end of the day. They have physician order entry. They set up their nurses to be able to take incoming calls for patients with symptoms. They have empty space in the schedule that day, so if patients have a symptom, they come to the office rather than go to the emergency room. They have created a navigator, so instead of patients collecting all their information, someone from the office actually collects the information, makes all the appointments, directs them to social support services. They've reduced their emergency room use 68%, because common things which used to end up in the emergency room, nausea, vomiting, dehydration, pain control, are now handled over the telephone 77% of the time, or in the physician's office an additional 10% of the time. Only 5% of patients do they have to send to the emergency room now. They've reduced their hospitalization rate 50%. When it comes to end-of-life care, any patient who presents with metastatic disease and is incurable, therefore, or has a change in what's called performance status, the amount of activity that they can handle, which is a very bad prognostic indicator for not living a lot longer. They address the goals of care, they do an advanced directive, and they begin palliative services. And they've increased their hospice length of stay 34%. I think these are the kinds of reforms we're going to see. Is every experiment with this going to work? Is every experiment that does work easily replicable in other scenarios? Probably not. But we don't need to hit 100%. We need to try these, refine them, and keep working at it. And when I say we're going to go to GDP plus 0, that's not next year. It's by the end of the decade. In 7 years, we're going to figure out what works. We're going to expand it, and I think we're going to have bigger changes. And what's the budget impact? Well, this is a slide from Altarum, which is a medical consulting group. And what they show here is that if we have the projected deficit, this is with taking away the Bush-era tax cuts. We know we didn't do that completely. We have, as far as we can see, deficits forever. That's with the usual health care spending that had been projected of GDP plus 2%. On the other hand, if we go to GDP plus 0, you have basically a $1.3 trillion swing in 25 years. This is the importance of getting health care spending under control. So I'm on the left of the political spectrum, and I focus exclusively on costs, and focusing on costs because it affects everything else. It affects the federal budget, it affects wages, it affects what states can spend on education. It is important. So that leads me to my conclusion. I know that the people in this audience are the masters of the universe, but I also know that if what I've said is true, doctors are the key to the future and the viable financial future of the United States. Because it's only doctors who can change how we deliver care and how we actually transform the delivery of care around patients with chronic illness. And if they can do it and get it right, and we can provide them with the right incentives, they will, I think, reduce what we're spending on health care and get us to GDP plus 0 with this dramatic effect on the federal budget deficit. Thank you very much.
Good morning. It's great to be here with you and great to follow Zeke. It's also a pleasure for me to be back at SIEPR, previously being part of John Chauvin's programs in its earlier and much more modest days, and now as part of such a distinguished gathering with all these masters of the universe. Gosh, it's nice to see Vic Fuchs here and Alan Enthoven. They helped me get started in health economics when I was at Stanford, and it's completely understandable after hearing Zeke's remarks why the background for the presentation switched from the capital to money, since that is such a big part of what's going on in healthcare and our overall economy now. And I'm going to give you a little bit, I'm going to take those same numbers that Zeke talked to you about. It's a great foundation for my remarks, and Zeke's point about the importance of having healthcare reform that is real healthcare reform, not just changing the policies and moving the incentives around, although that does really matter, but focusing on this goal of getting to better health at a lower cost. That I think is the key going forward. And ironically, I think the best way to do that is actually to stop talking about cost cutting in healthcare as much as we've been doing. I don't think that's worked very well. But let me set that up by taking off on Zeke's point about what's going on with Medicare spending. In the entire history of this program, up until the last few years, if you look at any sustained period of time, Medicare costs per person have been growing substantially faster than the overall economy. And no question, that compounded across other healthcare programs is the big story for why this is. As I think the earlier panel made clear as well, why healthcare costs are so important to the long-term fiscal outlook for the country. And as I'll show in a second, actually I'll go ahead and show it now, for the states as well. These are numbers from the National Governors Association on what's going on right now with state budgets. So if you divide spending changes, this is between 2011 and 2012, into the main things that state governments do, there's Medicaid, and then there's everything else, and pretty much all the increases are going into Medicaid. Prisons overall nationwide were holding steady, but the increased spending on Medicaid means less spending on primary and secondary education, early childhood programs, low-income programs, and public assistance, infrastructure, and everything else. So it's the same story that we're seeing happen at the federal level, too. What I think is important to emphasize, though, is that although these are not new stories, these are stories, if you looked at Zeke's numbers, they've been going on for decades in terms of this steady increase in healthcare-related spending from growing healthcare programs, growing utilization, prices, costs of services. That's been a steady trend for decades, and it's related to, I think, what people really value in healthcare. I put this slide up just because it's sort of a recent capture of some of the trends in innovation in prescription drugs and biologics in the United States. As you heard earlier, there's been a bit of a slowdown in recent years in new drug approvals. There's this sort of generic cliff that people are talking about now, where because in the past decade there haven't been as many new drugs approved, especially breakthrough drugs. So you see that drop down the line starting around 2006, 2007 or thereabouts, and that's starting to pick back up because there has been a retooling in the pharmaceutical industry. I'm going to come back to this a little bit later, away from a lot of the medications that kind of worked and were the focus of investment in the 1990s, drugs that were blockbusters, and in many cases Me Too blockbusters that had similar mechanisms of action. That's not the way investment is going much anymore. It is much more based on genomics, big data, predictive modeling, and complex systems biology analysis, which we're getting a better handle on, which is supporting a fundamental trend in medicine, and that is a trend towards more personalized or individualized and prevention-oriented care. So whereas 20 years ago, a lot of healthcare was about dealing with problems after they happen, taking your diabetes medications, your insulin after the diabetes had been developed, going in for the operation to clear your arteries after you had developed the heart disease. Now, healthcare is much more about earlier interventions, knowing your genomics, knowing predictive models for disease development that are resulting in much more individualized and prevention-oriented treatment for patients that is even taking a lot of healthcare out of what has traditionally been healthcare. Many of you who are working with employment-based plans today are doing big programs on wellness and other initiatives to help head off some of these costly complications before they happen. And I think what's really going to be driving healthcare reform is two things. One is that hasn't changed, is that people are still going to value health above pretty much everything else. And this is not a bad decision on their part. There have been studies done. I think I cited them in one of my previous talks here at the SIEPR Summit by economists like Bob Topel and others, showing that if you look at the value of the improvements in health that have happened over, say, the last half century, longer lives, they even count improvements in quality of life, which we've seen for a wide range of conditions. It's not even close in terms of increased spending versus increased value. So according to their calculations, the increased value from healthcare and improvements in biomedical knowledge and what we can do to prevent health problems over that time has exceeded the value of innovation in every other sector of the economy combined. I mean, it's not that we don't like iPods and jet travel and all that kind of stuff, but what we really like is the time to enjoy that, or the time to enjoy the sunsets and family and things like that. And so when push has come to shove, every time we've had one of these big policy debates about healthcare spending and cuts versus other spending cuts, healthcare has always won. And if you had any doubt about that, just look at what happened in this past few months with sequestration, where all of the cuts are once again, as we've steadily seen happening over the past decades, coming out of programs other than the healthcare entitlements, coming out of discretionary spending, defense spending, research and development, infrastructure, things like that. So if we really want to get this debate to change, while on the one hand, we've got more innovation coming along that can potentially be very valuable, and a great willingness on the part of the public to support access to innovative care, we've got to find a different way to have this debate than just focusing on cutting costs. I think what is starting to happen now is a change in focus. You know, Zeke did a great job of going through some of the recent trends in overall healthcare spending, where we've seen a slowdown starting to happen before the economic slowdown, some questions about whether that's going to be sustainable or not. I personally don't think it's going to be sustainable without some reinforcing policy changes that focus on value and quality much more so than just on trying to achieve short-term cost reductions by cutting physician payment rates further and the like. But I want to put this slide up to illustrate one of the key ideas, for those of you who don't follow this stuff closely, in financing reform that's happening in healthcare now to change this debate from being about sort of the usual one of cutting benefits or cutting payments to providers and hoping for the best in terms of more sustainable healthcare spending and generally not getting it, and instead focusing on what we really want and what the public really wants, which is better health without unnecessary healthcare costs. What they don't want is reducing costs in a way that could put them or their loved one's health at risk. That's what the policy debates, I think, have shown us over and over again in recent decades, right up through sequestration. This is a chart taken from some early work that we did while I was at CMS back in 2004, 2005. We did implement the drug benefit. I'll come to that in a minute. But we also started some pilot programs around payment reforms. You might think about, well, if you were at CMS and having a meeting like the one I'm about to tell you about, what would you do? I had a lot of these meetings. So this was the one I'll talk about in particular is with the heads of some physician group practice organizations. So these were physicians, like Zeke was talking about, who wanted to change the way that care was delivered, and they were actually going ahead and doing it. They were doing things like sending emails to their patients who were Medicare beneficiaries who had not gotten recommended evidence-based screening for cancer or their flu vaccines or things like that. They're doing these widespread emails to their whole practice. They were implementing some of the team kind of approaches to care that Zeke was describing for cancer. You can do that for other conditions too. So for patients with diabetes or heart disease, a big problem is that half the time in many practices, patients aren't on and aren't adhering to medications that are known to avoid the costly complications of those diseases, lead to better outcomes. There are also behavioral issues involved too. So they would set up teams of usually not just physicians, not even mainly physicians, but nurse practitioners, pharmacists, other allied health professionals to identify and intervene with these patients who were having problems using healthcare effectively with the goal of preventing costly complications. They were setting up teams for their patients with major illnesses that were going into the hospital to help make sure that there were smooth transitions when they left the hospital, prevent those readmissions. They were doing palliative care programs, something that Medicare doesn't pay for distinctly in its traditional program, not because they were trying to reduce access to ICUs, but because some of their patients with advanced illnesses were not getting the care that they wanted and were having problems with pain control and other things. So nurses to provide supportive care in all all of that. And they showed me a bunch of numbers, a bunch of measures that these were actually leading to better results for their patients. They were getting prevention rates up, they were getting better results for their patients with chronic diseases, and they would seem to be lowering Medicare costs. And Mark, the problem is that we're doing these things and we are getting killed. Number one, because all those things that I just described, Medicare doesn't pay for in its traditional fee-for-service payment system, nor did at the time a lot of private insurers. This was not the way traditional healthcare had been done. If you just add in more services to your fee-for-service program, and the actuary will tell you that costs will go up, there will be more utilization, it won't be well coordinated, and so forth, so it generally doesn't happen. Even worse in Medicaid programs at the state level. And then number two, we're getting killed because to the extent this stuff actually works, we get paid less for the things that Medicare does reimburse. You know, fewer hospitalizations, fewer office visits, fewer MRIs and lab tests and things like that. So we can't do these things that we think are like real needed healthcare reform and still make ends meet in our practice. So we started a pilot program in Medicare, and it's an idea that's been reflected. You know, we weren't the only ones doing it, but it's an idea that's been reflected now in a lot of private insurance plans working with healthcare providers that are now moving a lot farther along in some ways than Medicare. I just set up a second payment stream which was based on what we thought healthcare should really be about and what we did want to reinforce, and that's better health at a lower overall cost. I've been identified by a lot of people who follow this health policy stuff as being a big supporter of so-called accountable care organizations, which are about setting up this second payment stream. And what it involves is not only having your traditional fee-for-service payments where you get paid more for more volume and more intensity, but also having a second payment stream that's about tracking some of these measures as best we can measure them of what really matters for the patients that you are accountable for. So things like the use of effective screening tests in your general population, things like the extent to which blood sugar and blood pressure and cholesterol levels are controlled in patients at risk for all of those diseases. Things like getting down hospitalization rates with preventable complications. Things like patient measures of their experience of care. Are they getting the care that they wanted? Do they understand their plan of care? And the deal was, in these pilot reforms, which have now become much more widespread, is that if the providers could get better results on these measures, and if we in Medicare saw a reduction in overall cost trends, not just the payments we're getting to the physicians, but overall, things like resulting from less hospital days, fewer hospitalizations, fewer readmissions, things like that, then the groups got to keep some of those savings after a threshold. Now, what many of the organizations that have implemented these kinds of accountable care payment reforms, or ACOs, have done, and there are a lot more of them now. We track this in a kind of Brookings-Dartmouth collaboration that we have based in our organizations. What a lot of these organizations have done is they start out with that idea of sort of a second track of payment that just consists of shared savings. So this is back to healthcare. This is something people care deeply about. They don't want radical change that's going to significantly upset the way that they or their loved ones potentially get their care. This is something that can be done more incrementally but add up to fundamental change. So you set up that second payment track, and as you get more experience with dealing with the uncertainty that many organizations face today and knowing what really is going on with their patients at the patient level, where else are they getting care, what can we do about it, what really does work to prevent complications without adding to overall costs, they've moved more of their payments into that second track. So these are things like two-sided risk or partial capitation or something moving away from fee-for-service. So a lot of those Medicare Advantage plans that Zeke was talking about before have payment systems for their providers. And a lot of private health insurance plans like Blue Cross of Massachusetts have payment systems for their providers that are now not just or even primarily about volume and intensity, traditional fee-for-service, but about better results and lower overall cost trends, something like holding overall cost per patient to GDP per capita growth while improving quality of care at the same time. It gives them a lot more flexibility to spend the money on the things that matter, the combination of treatments that matter, and more individualized care for patients. I'm not an advocate particularly of thinking that ACOs, this model by itself, is going to be the solution for the country. But what I do think in terms of financing reforms is that the principle of accountable care, meaning paying not just for volume and intensity, but for better results at a lower cost, is the future and is a way to make these kinds of real healthcare reforms actually be sustainable and pay off and actually provide a pathway whereby if you were in medical practice today and you come up with a better, cheaper way of delivering care, you don't get punished for it. In every other industry, you see cost-saving innovation in part because it pays off economically. That hasn't been the case historically with healthcare financing systems, and particularly in public programs like Medicare. So it's not really about ACOs, but it's about this principle of moving from paying based on volume and intensity to paying based on better results at a lower cost, and finding an effective way to do that that brings the public along. Ideas that fit into this same framework are things like medical homes, so paying primary care providers, not on how often they see their patients. They get paid a lower and lower rate for each visit and so forth, but instead based on how their patients are doing. Are they getting better care? Are they happy with their results? Are their overall costs lower? Paying specialists who are working together, not based on how many times their patient who had to have a bypass operation, how long they spent in the hospital, how many times they went back for complication visits, but an overall payment based on how well did that bypass operation turn out. Was the patient back at work sooner? Were there fewer readmissions? And were there lower costs as a result of that? This, by the way, is much more like the way that payments work in the non-third-party insurance parts of healthcare, like IVF treatments, cosmetic surgery, things like that, where it's much more of a bundle payment that the consumer is responsible for, and measures of quality, measures of result that go along with it, so you don't have to figure out from 10,000 fee-for-service charges and a charge master or something like that, have any hope of finding out what things really cost, let alone what the quality of the care that you received really was. This is hard to do. It's hard to measure quality. It's hard to implement these changes in traditional payment, but it is coming along. So that's I think the one key idea for the provider side of healthcare financing reform. Again, it's not about lowering costs. It's about getting better results and giving providers more flexibility and accountability in doing it. It's happening both in the public and private sector. Zeke talked about the reductions that have been going on in Medicare spending recently, which is my segue to talk about what I think is at least as powerful, if not more powerful, tool for driving these kinds of changes in healthcare, and that is more engagement with consumers, with healthcare, with Medicare beneficiaries, with privately insured individuals on similar steps for getting cost reduction. I mean, if you think about it, the same kind of approach to volume intensity is the way that third-party insurance has worked for consumers as well, right? You spend more, you get more payments from your insurance company. Eventually, you hit an out-of-pocket limit where everything's paid for by third-party coverage, and that reinforces the same kind of variations in care, the same kinds of inefficiencies that I've been talking about here. Something that would be focused more on results for patients is something like what I think we've seen with Medicare Part D implementation. So I'll go back and tell a story in just a second, but I just want to show you the graphs first. This is a comparison of what Medicare Part D was projected to cost before we started implementing it in 2006. This is the drug benefit within Medicare, and then the darker line at the bottom is actual costs, which are continuing to run about 40% below projections. The average rate of increase in Part D since it was created in 2006 has been about 1.5% nominally in premiums, so way below rate of GDP growth and so forth. Even with the recession, this year premiums are lower than they were last year. And in fact, if you look at the changes in Medicare projections, so this is the changes in the overall cost of Medicare that are projected out for the next decade, they've gotten so much better. Break that down into pieces. So there's Part A, that's hospital costs. Those spending trends have improved, reflecting what Zeke described as a sort of less readmissions, also a somewhat slower trend in terms of admissions. Part B is physician and outpatient services and home health services and things like that. That's still going up. That's still also, by the way, the most fee-for-service part of the whole Medicare program. Part D has been low and has come down even more and accounts for actually a majority of the changes in outlays projected for the overall Medicare program. in the last few years. Behind this is, I think, a lesson about consumer involvement. So when the Medicare law was passed, it was done, as many of you may remember, as controversial, and it was done through competing private health insurance plans providing drug coverage. And there's even a question whether that market would even exist. I think it's maybe some relevance to some of the debate about what's going to happen with the ACA going forward and the new health insurance exchanges. But the law included a standard drug benefit, which was a traditional kind of design. It had a deductible, 25% co-insurance, catastrophic coverage on the back end. It also had that famous donut hole in between because the costs projected at the time were much higher than they turned out to be. Do you know how many people are in that standard drug benefit today? How many seniors are? Almost none. And the reason was that when the drug benefit plan was set up, it included this competitive approach for coverage where plans could offer so-called actuarial equivalent benefit designs, and they did. And I remember when we were out touring the country and encouraging seniors to find out about this program and telling them how they could do it in 2005, I heard an awful lot of frustrated seniors. Why the hell can't you just give us a drug benefit? Why are there 50 different choices? And why do I have to spend the time comparing them? Just give me a drug benefit. Well, seniors did spend that time and effort to look at different plans, and what they overwhelmingly chose were plans that had tiered benefit designs, where the generic drugs, the most cost-effective drugs on the market, were basically free. They cost maybe $1, and the plans would cover preferred brand name drugs. Remember all that, the Me Too drugs that were kind of the hallmark of the 1990s and early 2000 innovation for prescription drugs. The plans would cover a couple of those for things like lowering your cholesterol or controlling your diabetes or dealing with allergies and things like that. And they would cost maybe $30 a month, kind of a flat rate. And everything else, the plans had very broad formularies, but everything else would be on a higher tier, meaning compared to a traditional insurance design, if Mrs. Smith switched from a brand name beta blocker, say for high blood pressure, to a generic one, she didn't go from paying $25 a month to maybe $3 or $5 a month. She didn't save $20. She saved basically the full difference in cost. So going from like $89.50 to $1. And what seniors overwhelmingly did and did not complain about nearly as much as we were expecting. They complained a lot about the confusion with the choices. They complained a lot about the startup problems of having their data match up with their cards when they first went to the pharmacy. Fortunately, we were able to work through a lot of those issues. But they didn't complain much about these switches. So we have this, as Zeke mentioned, not only a big switch from brand to generic drugs, which leads to huge savings. You're not talking about just like negotiating prices down another few percentage points. That's like an 80% difference in cost per prescription. That's how you get to significant cost savings in healthcare, by really changing the way that care is delivered. The second thing is they switch from non-preferred to preferred brand name drugs at such high rates that pharmaceutical manufacturers no longer invest much in doing Me Too drugs. They are all focusing on drugs for unmet medical needs. Now, there's still some issues about how much those cost and the impact for long-term healthcare cost growth, but it's not about the Me Too's anymore. And the result of all of this has been much lower spending growth in this part of the program than anybody expected. Now, there are other contributing factors too, and we can talk about all of those, but what I want to leave you with is just thinking about what this means for really getting to reforms that the public can believe in that save money in healthcare. What the tiered benefit approach really means is that consumers have more opportunity for savings at the margin when they get the care that they need at a lower cost. And we've seen it in drugs. Seniors absolutely have proven that they believe that brands and generics are equivalent, that brand name drugs that work a lot like other brand name drugs out there are pretty much equivalent, and they fundamentally change their behavior in ways that have had big financial consequences, big cost savings without, and this is very important, without thinking that they're losing access to the care that they need, that they're losing, or their mom's losing access to quality care. Think about if we could bring that to the rest of healthcare. If we had valid measures of quality of care and overall cost for things like bypass surgery or colonoscopies or other procedures. In the private sector, many employers are now starting to change their benefit designs to reflect these kinds of principles, to engage consumers much more in this same focus that I was talking about on the provider side of getting the health care you need, that gets you, for which you're confident that you're getting good access to care, you're not compromising on quality, but if it can be done much more cheaply, giving you the opportunity to save a lot more than a traditional insurance design. So we're not there yet. I don't think this is by any means a sure thing, but I think this is a potentially effective way forward for getting to something like Zeke's optimistic goal of much lower healthcare costs for the future. It's not going to just involve changing the way that providers are paid, but really facilitating and encouraging much more patient and consumer engagement in healthcare. Thank you all very much for the opportunity to join you today.
Let's start. Zeke, do you have any comments you want to make on the presentation?
I would echo something that Mark said. So one of the big issues is how are the exchanges going to play into this? And I think there is some skepticism out there. Again, maybe because I'm in California, I'm optimistic about it. I think we're going to have 2 or 3 years of bumpiness. And let me be clear, we're not going to open on October 1st and everything's going to be hunky-dory and it's going to be like shopping on Amazon. That'll take 2 or 3 years that's the goal. That'll take 2 or 3 years to work out. But let's figure out what's going to happen when you do open an exchange. You're going to change the insurance model. No longer is insurers are selling to businesses. They're selling to consumers. Very different model, right? Businesses, they talk about wanting cost control, but frankly, HR that buys most of the insurance is interested in kvetch reduction, right? Getting the minimal number of employees complaining. And that leads to wide networks. It leads to not actually worrying about reduced cost sharing, not worrying too much about costs. On the other hand, in the insurance exchange, we know from Massachusetts, 60–70% of people buy on one and only one thing, and that's going to be cost. As long as they're assured that that cost at the low tier is high quality, they're going to buy on that. And that is going to force insurance companies to create these tiered products that Mark mentioned, hospitals that are high quality and cheap. And that, I think, is going to drive a lot of hospitals. It's already driving them to figure out how to wring costs out of their system. Because even great academic centers like Stanford cannot run on just a few patients. 80, 90, 95% of what they do is bread and butter. It's not the complicated transplants or the complicated chemotherapy. It's, bread and butter stuff. And they're going to have to get that to be very efficient under Medicare costs. And I think you're going to see a big drive, therefore, to get lean into hospitals, to wring a lot of costs out of the system. Again, it'll take a few years, but every hospital in the country right now is working on that. It's going to transform things. We're going to see MRIs at 2 in the morning. We're going to see 7-day surgical time slots to make much more efficient use of the health system. And, by the way, you come in at 2 a.m. to get your MRI, you won't be paying a copay. And it'll be efficient, much more efficient for everyone. So I think that's going to be a major, major thing. Let me emphasize one other thing, and I want to echo what Mark said. How we pay and transforming how we pay is, I think, very, very important. Because under the fee-for-service system, if there's one change I could get if I was the healthcare czar in Washington, we got to get off the fee-for-service system, and we have to do it on a schedule, predictable, so practices, hospitals, home health care agencies, everyone can adapt. But that is going to be critical to incentivize these transformations. A lot of the places that have done it have either been Medicare Advantage plans or places like that oncology group I mentioned have really done it despite the fact that they have lost a lot of money. I have an op-ed coming out with a bunch of 20-plus community as well as academic oncologists basically saying, including the former president of MD Anderson, saying, well, we want to be paid in a different way. We want to get off this fee-for-service thing. We don't want to make money by giving more expensive chemotherapy. That change in attitude 5 years ago was nowheresville. And now I think it's throughout the healthcare system wanting to experiment with actually doing what we do best, managing patients for high-quality care. So I do think that what Mark said about the insurance exchange from Medicare shifting into these exchanges on the states is going to have a big impact. And I think to really catalyze these change in how we deliver care is going to require payment reform on a much more aggressive schedule than we have in the law now. So I don't think just with what we have we're going to get to GDP plus 0, but I think with what we have and probable changes in Medicare.
And Mark, if you were co-healthcare czar, what would be the one thing you would do?
Fire me, obviously.
Well, the big new thing is implementing the exchanges, and those are shaping up to be kind of bumpy. The implementation of Part D had some advantage going for it compared to the current insurance exchanges. We had a chance to get the regulations out earlier and be very clear about these rules, very clear with the insurance companies about things that they couldn't do and the innovative products that they could offer and steps that we would take to make sure that if they designed a good product that was delivering good access to drugs, they weren't going to get hammered in the first year because of unfavorable risk selection. So I think there's still some work that needs to happen there. We also did a lot of work on outreach, and this was not happy talk about, oh, it was great, we have a new benefit, but local efforts around the country to help make sure people could get information from those that they trusted about what the drug benefit really meant to them. And it meant partnering with a lot of organizations and groups that were not supporters of the law, but that still agreed, yeah, we want to get the basic facts out and help people enroll if it's the best thing for them. And that's been very hard to do this time around. So I think the upshot is, I think this aspiration that Zeke was talking about for exchanges, it's going to be hard to see that in the first year, at least all over the country. There's some states, California has been doing a lot more work, some state-run efforts that are farther along. I think you'll hear more about that this afternoon. But it's probably going to be a gradual process. In any event, it's going to be a relatively small part of the overall healthcare market for a while. So need to make these changes in Medicare more aggressively and need to support changes in employer coverage that would encourage employers to help to offer health plans that are more like, that really give people an opportunity to save. High deductible plans do that to a limited extent, but no matter how high the deductible is, the vast majority of spending is above it. So you're admitted to the hospital for one day, and you're into a zone where it doesn't matter, and that's why we need these kinds of reforms.
So any questions? I'm sure there are. Questions from the audience here. Wait till you get the microphone. I know that's a little inefficient, but right here.
I wanted to quietly argue with one of Dr. Emanuel's statements at the very close. He said, in the end, the doctors will determine the nature of health care. That's more or less a correct quote. Well, no doubt.
I said they'd save the country.
Okay.
Even more bold.
That's less important.
Yeah, okay.
There's no question, of course, that doctors will deliver the health care, but the way health care is delivered, it seems to me, will be determined by other people. Doctors such as yourself are intellectual leaders, but in the end, the politicians and the system will determine how doctors deliver health care. Would you agree with that?
You're accusing me of being hyperbolic? Oh, really? So let me, it is true that a lot of policies have to be put in place. They have to be put in place by the government. They have to be put in place by private employers and private insurers. Remember, they still pay more than half the dollars in the system. Nonetheless, those incentives will not be effectuated in better care and reduce costs unless doctors get on board and doctors are enthusiastic about it. We know that doctors can gum up the system pretty well and prevent lots of good programs from getting actually implemented well if they're not behind them. And I think one of the things we need to do is to persuade doctors that, yes, there's a lot of uncertainty now, but in fact their lives are going to become better. And one of the ways I actually think it's going to become better is they are going to take financial risk, but they're going to have more control over how they deliver the care and what combination of things they do. And that, I think, has not been well communicated to them. They're very nervous. I would also say that another reason I'm positive is that the younger generation of doctors, using electronics, using data, they're much more experienced than, people, me and older. And I think that will help this transition a lot more. I think it's an important selling job, and I think we underestimate how important it is. But I go back to the fact that this is the 5th largest economy in the world, and you don't expect to transition it overnight. It's going to take a decade to transition it, and there are going to be bumps along the road. It's not all going to be smooth, and I think we need to be upfront about both of those things. So people have to have the right expectations. But I think once you have the right incentive structure, doctors are going to use better wireless monitoring. They're going to figure out how to make compliance with drugs more efficient. I think house calls are coming back because they're much better than going to the emergency room, right? Emergency room is $1,500 for a single stitch. You can do a house call and do that a lot more efficiently. And so I think we're going to have big, big transformations in how we deliver care.
I think there was a question right back here. Is there a microphone near there?
For Zeke, I'm curious, that graph that you put up early on that showed the U.S. and the huge gap between the U.S. and the line. I'm curious if you've looked into and thought about the composition of that gap between the cost or the price of a unit of health care, if you will, and the number of units we're buying. That is, are we getting something for our money?
Fortunately, that graph's from McKinsey, and they looked at it very carefully. And if you actually decompose the international comparisons, for example, between us and most of Europe, a large part of that is prices. So we pay a lot more for drugs. Our doctors make a hell of a lot more money than doctors in Europe do. They may have more prestige than American doctors do society-wide, but they actually make comparatively less than American doctors do. So prices on the international comparisons. Then you make comparisons inside the country. It turns out that a lot of the variation is on utilization inside the country. About a third is price differentials between different parts of the country, and about 2/3 is utilization difference. So we know that there's a big difference about how patients are managed, say, here in the Bay Area compared to how patients are managed in other parts of the country. Just, for example, pick Miami. Much better, more efficient here than it is in Miami. And so I think the conclusion I've come to, we got a price problem and we got a utilization problem, and we need to attack both. So I'll give you, what do we do about the prices? Well, Medicare, as part of the Affordable Care Act, one of the things I'm proud of helping out on is put in a competitive bidding process for some parts of the Medicare expenditures. No one, whether you're on the left or the right, thinks that the government setting prices is a good way of establishing efficiency and providing the right incentives. Why do we tolerate Medicare? So when we buy a wheelchair for someone at home, or a hospital bed or oxygen equipment, we've had price setting. So we put in, you got to have competitive bidding, first in 100 MSAs and then expand it nationwide by 2016. First year of the program, we've got about 40% savings on those prices. Obviously, there's a group which doesn't like that. They're called suppliers, right? They just saw their profit margin hit big time. And, truth be told, they have a lot of complaints about the way Medicare ran that auction. That's not Medicare's expertise. We could run it a lot better. We've made some suggestions about how to do that. But I think on the supplier side, you have to expand that kind of competitive bidding. Get rid of the government in this process. I've suggested, lab tests. Let's put that on a competitive bidding model. Probably make some of the people in the audience here a little uncomfortable. What about devices? We've had wide variation in prices and devices across the country, like the hips and other things, the actual hip prosthesis. Let's put that on competitive bidding. So we have ways of bringing some prices down. Another thing we obviously have to do is incentivize different utilization. We have to change how much we're doing of certain things. And I'll give you, just my example. I'm an oncologist, so almost everything I talk about comes back to oncology. Here are two examples. We did a study about, 8 years ago, randomized study for zapping bone mets. So when someone gets cancer of, say, the prostate or breast cancer in the arm, the main issue is pain relief, and the main treatment is radiation. And a study showed you zap it with just one dose, 1 day, 1 visit, versus 10 days, 2 weeks of basically of treatment, same pain control. So you'd say, well, why don't we go to one? It's better for the patient. They only come into the hospital once. The pain control is the same. Actually, patient satisfaction is better on that. Shift 2.6% of all radiation for single bone mets is once. Why is that? No brains, right? Doesn't take any brains. How much do you think we pay for 10 doses? And how much do you think we pay for 1? So we got to change that payment model, and we'll get a different kind of utilization. And there's a lot of savings there. Let me give you another example. If you get stomach cancer, right? The NCCN has 5 different chemotherapies that's basically functionally equivalent. The price difference on those 5 different chemotherapies, 55-fold price difference. Huge, right? If you're an oncologist, you make the price of the chemo plus 6%. Now, what's your incentive structure? Doesn't take a genius to figure that one out, right? So we have to change these incentives, and then if I don't make more money by giving the $55,000 drug treatment and I make it, you know, by doing good care for the patient, we'll see a change in how we practice. I gave you 2 examples from oncology. I assure you, examples exist in every part of medicine, whether it's GI or rheumatology or cardiology or wherever your favorite doc is practicing.
George? Sorry, did you want to comment on that?
You mentioned that drug prices are higher here than Europe. My impression is, but I'd like you to comment, that we have a much more creative system, and far more drugs are created and developed here. So they start here, and then the prices get pounded down in Europe. If we went to European price system, the flow of creative new pharmaceuticals would go to the European level, which is very low. Is that correct?
Why don't you start, and then I'll...
Well, the pharmaceutical markets now are pretty global, but no question that the revenues from the U.S. market are the big driver for returns on global innovation in pharmaceuticals. And it's just a couple of comments on that. One is that the pricing reforms that I talked about with Part D and that are now very common in the U.S. have driven the U.S. market much more in the direction of generics than virtually all of the rest of the world. You can even see this between, say, Medicare and Medicaid, where in Medicare there are these strong price differences that patients see, so they can get the savings when they use a generic drug, a drug that's not truly innovative, but that does the job and has been around for a while. Versus in Medicaid, where we've had a system of price regulation much more European-like, and there's sort of more use of brand names, less use of generics. The net cost effects, I think, may probably benefit the Medicaid program, but certainly don't drive innovation. I think if you really want to get to innovation, the first emphasis has to be on valuable treatments being able to get some returns, especially given all the uncertainty in their development. A lot of the work that we do now is on how to make the development process more efficient, more predictable, and get these treatments to patients faster, but it is a very long and uncertain process now. You may know more about some of the other areas where these global incentives matter, but the U.S. is also paying, I think, more than a majority of the cost for international security around the world. It's something that's sort of public good that we provide elsewhere. My hope is that the kinds of reforms that we've talked about today can get, there clearly are a lot of opportunities for savings in healthcare through preventing illnesses, for getting care right. And there are so many opportunities for biomedical innovation that I think if we make these kinds of reforms, that'll do more to promote both innovation and keeping overall costs down, rather than some of the price control approaches, which might keep overall costs down but don't do nearly so much for
So I think Mark has made a good point that no drug available here that's really not available in Europe, and sometimes they approve them before we do. This is a worldwide market. And I'm sure there's some people in the audience who know more about it, but about 5 or 7 years ago, U.S. accounted for 60% of the drug company profits. Now it's crept down. I think we're at 40 or 43, 45% of the drug company profit. And it is true, that drives a lot of their investment, and a lot of their investments here, but they have labs all over the world. You know, Novartis is not just based here in the U.S. Their labs are not just based here. There's a worldwide development process and a worldwide market. I would say the last point I would like to emphasize is, the real issue is not do we have new drugs here. The real issue is, do we have the panoply of interventions that improve the quality of care and reduce costs? That's the real question. Sometimes it's going to be drugs, sometimes it's going to be devices, sometimes it's going to be just getting people to do the things that we already know work. So when I was training, what did we do with patients? We sent them out of the hospital with a stack of prescriptions this big. We expected them to fill them, and we expected them to take them properly. Any chronic condition, got 7 or 10 drugs, right? And we found out, about 70% of the time they actually filled the prescription. So 30% of the time they're not even filling the prescription. And then of that, 70% of the time they're actually taking the drug properly. Frequently they got the drug, but they're just not even taking it. So one of the great new innovations is a new bottle cap on those pill capsules you get from pharmacies that have an LED attached to it, indicate to the patient whether they've taken the drug or not. If they haven't taken it by a certain time, a radio signal goes out to their doctor, a radio signal goes out to their family saying, they didn't take the drug. Compliance in small studies, and I don't want to oversell this, in small studies goes from like 70% to 98%. Now, that's not a new drug, but let me tell you, that's probably a lot more effective getting people to take their drugs than developing a new drug for whatever it is, cholesterol or hypertension. So we have to look at the overall innovation of the system. That, I think, is a big innovation, just as important as getting a new drug out there for whatever the disease is. And so I think there's going to be a whole new set of innovations. It may not be a new pill. It may not be a glitzy robot for surgery. But that doesn't mean it doesn't make a big improvement in health. And so we really need to look at the right outcome. And I think this new system that we're having is going to have a much more emphasis on improving quality and getting a price point that's tolerable.
Hey, you have a question here?
Thank you. This is a question on the tension between the federal government and the Affordable Care Act and the states with respect to which state chooses to do their own exchange or have the federal government do it, as well as on Medicaid expansion. I was wondering if both of you could comment on what you think the implications are of these different decision frameworks.
Maybe I'll go ahead.
Go ahead.
Okay. So starting with Medicaid, I think one of the underappreciated features of the Supreme Court decision on the Affordable Care Act last year was just how much more flexibility that gives states in running their Medicaid programs overall, not just in whether or not they can decide to expand from what they have now to childless adults up to a higher income level, but also because it affects their overall negotiations with the federal government, what they're doing elsewhere in the program. So now you're seeing things like the state of Arkansas with a Democratic governor, state of California wanting to do things that are much more capitated in Medicaid, maybe much more relying on private managed care plans than I think was the case even a few years ago. I think that's a reflection both of these fundamental trends towards more person-focused care that we've talked about and towards a greater state negotiating position. That's still playing out, and I think it does mean that a lot of states are not going to expand Medicaid coverage right away, and that before we get to broad coverage expansions, you will see some further evolution in the way that Medicaid coverage works, probably more in the direction of managed care, maybe even tiered benefits, things like that we've talked about before. On the side of the exchanges, I think one of the things that the supporters of the law probably didn't develop, and you didn't expect, but you could comment on this, was how many states would be relying on the federal government for sort of all or nearly all of implementation. So a majority of the states and a substantial majority of the uninsured Americans are in states that, like Texas and Florida, that are not doing exchanges and are relying on the federal government. As we talked about earlier, that's been a challenging process for the feds. The regulations have come out on a very tight time frame. The final regulations, the last part of them were just out a week or two ago, and the bids for the plans that are competing in these exchanges are due at the end of April, and there still are a lot of questions about how this is all going to play out. And then there's all these issues around getting people to enroll for Medicare Part D, these early and very extensive, very broad-based enrollment efforts were quite important in getting people who weren't entitled to just enormous subsidies and essentially free coverage to enroll because of their low incomes, or sort of moderate and higher income individuals. It was an outreach effort and people getting their questions answered, and it was also a deadline after which there was a late enrollment penalty, and that too doesn't really exist here. So I think for those reasons, in a lot of states, it's going to be a pretty slow start, and probably some efforts needed on the part of the administration to make sure, just like we try to do with Part D, to make sure that plans that do sort of a good faith effort to offer good coverage and end up getting not that many enrollees, the ones they do get are pretty seriously ill, that they have a financial path forward, and that at least over the next few years, if not in the first year, the market gets much more steadily established. I mean, history is on the side of these programs actually succeeding. It takes a while and a lot of bumps in the road. But I would expect to see some modifications along the way, depending on how this plays out, towards maybe somewhat more flexibility in the kinds of coverage that are allowed, and more innovations in coverage. And if those approaches work, then you'll see the programs expand more rapidly. This is going to be a slow and bumpy process.
Yeah, so let's, just a little political history here. The idea of state-based exchanges was developed in the Senate, and the House, in their bill, had a federal exchange. I have long been on record supporting the House version. As a matter of fact, if we had had a conference and we hadn't had the Scott Brown problem of the House having to basically adopt the Senate bill, I think you would have seen as one of the changes in that conference would have been a national exchange as opposed to a state.
Happy because we're getting mostly a federally.
No, I am not happy because we got mostly a federal exchange after giving states a lot of time, so the federal government didn't have an adequate time and knowledge of how much responsibility it would happen. And now what we've got is a much more complicated mess than either one of them. So I'm not a big fan of this. Having said that, what we are going to have, we do have this sort of strange political arrangement where the states which have decided we're not doing this federal exchange are not only, but largely Republican states, which typically want states' rights and don't want the big federal government doing it. And the states that are pioneering the exchanges, California, Colorado, they're blue states. And it's a, crazy mess, as all American politics is. So it doesn't make a whole lot of sense, and it will mean that Republican governors are going to complain no matter what happens at the federal level. They simply want their complaining rights, even though they gave up the right. And there was, by the way, plenty of dollars to help the states develop their exchanges, almost fully funded by the federal government. The main reason I was against state-based exchanges, not every state has the capacity, like California, to really have really smart bureaucrats who can run it, who really understand how to set these things up and can call upon a pretty extensive network. And these are you guys are way ahead. You have a very good set of people developing this.
I think you lost them on smart bureaucrats. There's a question back here.
But I do think, again, this is going to be bumpy, but after 2 or 3 years, I think we're going to sort out the problems.
Okay, there's a question back here.
Yes, thank you very much, gentlemen, for a great presentation. When I think of the delta between the United States and Europe, 3 things come very quickly to mind. I would like your comments. First is, I think there's a large difference between the United States and Europe in terms of its legal structure and tort reform. Second, I think that the United States often has the wrong gold standards. If you look at the debacle with PSA, I can give you a dozen examples where we've told the public this is the gold standard and then it turns out not to be. And then the third is when I go to Europe and I come here, I see an enormous amount of obesity here and less so in Europe. So please, happy to hear.
So let's just take the first one, tort reform. There have been a lot of analyses of tort reform, and let me preface what I'm going to say by saying I'm a huge advocate of tort reform, huge advocate in the administration of trying to get tort reform. This president is a huge advocate of tort and malpractice reform. But if you think that's key for cost control, you're sadly mistaken. There have been a lot of studies of that, and at best, people are looking at sort of 10 or 11 billion dollars per annum, including the defensive medicine part and including the savings on malpractice premiums. In a $2.8 trillion system, that's pencil dust. You couldn't even notice it. So the idea that tort reform is going to be key to cost control, I think, is mistaken. Why I'm so powerful for it? First, I'm strongly for a safe harbor, so that if doctors follow guidelines, if doctors have a computer system, that they get a safe harbor, a presumption, a rebuttable presumption that they're doing the right thing. I think that'll improve quality. And the second thing, it'll take this issue off the table and allow doctors to focus on improving quality. I wasn't sure I understood the second point, but let me go to the third point of obesity. Obesity is a huge problem in this country. And let me make 3 points. The first thing is, it's more a problem in the future than it is today. It does affect diabetes rates and hypertension and all sorts of other things, but it's really a problem that's coming down the line. We do have more obesity than Europe. They are catching up there. The McDonaldification of Europe is fast apace. But we actually have lower smoking rates than Europe. And it turns out that those things, they don't quite balance themselves out, but they're pretty close. And one of the things I'm proud of is the fact that the administration didn't just do healthcare reform, but also did the First Lady's anti-obesity initiative on the idea that these are parallel tracks. You're not going to solve the obesity problem in the doctor's office. That's fundamentally a public health measure, a policy measure, and that has to be done as a public health measure. That's the most efficient way. And by the way, we know we can tackle this problem. How do we know? We've done a very good job, not solved, on the smoking. We've gone from smoking rates in the 60s of the mid 40% of adult population down to 18, 19% today. We know that it's a combination of things. There's not one magic bullet. It's putting warnings on them, like menu label warnings. It's making it socially unacceptable to smoke and pushing it out. It's putting taxes on system. It's getting it away from kids. We have a lot of knowledge of how to do that, and I think the same multifactorial approach has to be applied to food, and by the way, is being applied to food. If you look at the timeline of interventions on the smoking dimension and interventions on the food and obesity initiative, we're doing a lot more early on the food and obesity initiatives, and we're already seeing changes like how the consumption of bread and changes. I don't want to paint a terribly, we're not around the bend by any stretch of the imagination, but you have to see these as parallel tracks, and we do have to get our arms around the obesity initiative. But our really high costs in healthcare now, today, it's not really the obesity problem.
Just, I'm not sure I got the second point either, but
Let him ask the second question. So go ahead.
I'll explain the second point.
Okay, well, on the, just a couple of things. One is I do think that liability reform would be helpful. All of these individual reforms, if you go to scores and look at empirical evidence, I think some of it is a bit more compelling for major reforms in tort law than Zeke, but that may be just differences of views among health economists. I think changing that along with other changes that get to this much bigger focus on better health, lower costs, as opposed to more utilization of services and the kinds of things that are the focus of liability cases, would collectively have a bigger effect on the way that care is delivered, and would be really helpful in conjunction with these other, and reinforcing in conjunction with these other reforms. There's one other point about the international differences, and I think this ties into obesity too. The U.S. is a big outlier in terms of spending defined as health care. If you look at spending, public spending on health care plus social services, though, we're right in the middle of the pack. And a lot of the things that we do to support a lot of things in other countries that involve hospital stays that are for supportive care, things that we don't cover, are covered. And a lot of the reforms that we've been talking about today, I think, would do take some important steps to move healthcare to really being more about health in this country rather than just use of medical services. Some of the programs, obesity is a very difficult problem. It is behaviorally determined. There are some medical interventions in development now. The FDA has tried to accelerate the pathway for those as well, but is mainly a behavioral issue. And some of the employers that are now doing reforms about better results and lower costs are supporting programs that do earlier intervention, alternatives to surgery, things like that. Those kinds of things are not happening in public programs. in the United States now, just because of our focus on kind of paying for traditional volume and intensity of services rather than encouraging more innovation and getting to better health at a lower cost. So I think there are some potentials for addressing those differences through the kinds of reforms that are happening now.
Okay, we're out of time.
Oh,
We're out of
okay,
time.
sorry.
Can I be indiscreet and read your note at the bottom there?
Oh.
To close out. This is terribly indiscreet of me. This is the bottom note on Zeke's piece of paper. Doctors control the future of America. So thank you all very much. Good job. Good job, Mark. Thanks.